Hi, everybody. Thank you so much for coming. First of all, welcome back to Real Chemistry's Health Innovation Stage. My name is Brandon. I'm from Real Chemistry. I actually am the president of Europe, which actually, that sounds like a really cool title. I'm not the actual president here. For Real Chemistry, I oversee the European offices, but that gives me an opportunity to constantly learn about new cultures, linguistic differences, socioeconomic differences, cultural differences coming together, and so very appropriate to join my friends and colleagues here today. Just as a quick intro to this presentation, Trust and Tech, Patient-Centered Health Innovation. In an ongoing effort to innovate new technology in service of patients, very often trust is the missing link. So we have AI, we have digital health, transforming how we diagnose patients, how we treat patients, how we connect them. But the question is, who is shaping that technology and who's being left out in the process? So today, we've brought together health leaders and innovators to discuss centering patients and culture in design and data, and how that can lead to not only potentially better products, but also stronger relationships. So in short, technology itself can't build trust. People can. With that, I would like to introduce our panelists here, and we'll start with Josette.
Sure. So a pleasure to be here with you all this morning. My name is Josette Gbemudu. I'm the Associate Vice President of Patient Health Innovation at Merck. Merck is a pharmaceutical company. We have presence certainly not just here in the US, but around the globe. In terms of what I focus on and do, it's really centering patients at the heart of everything we do. And that requires us to better understand the challenges that patients experience on a day-to-day basis in terms of navigating the broader healthcare ecosystem. It's not just about, do they get access to our products, our medicines, our vaccines or not, but it's understanding all the stages and steps that it takes to get diagnosed, to really truly be connected to the appropriate treatment or therapy, and on and on and on. And of course, that is challenging, so they're going to experience a lot of gaps along the way. So we're focused on understanding what those gaps are and thinking about the right innovations, especially digital innovations, to reach, engage, activate, support patients, as well as even support providers along the way.
Great. Simon?
Hi, good morning, everyone. Simon Nazarian. I'm the Executive Vice President and Chief Digital and Technology Officer for City of Hope. For those of you who may not be familiar, City of Hope is one of the largest and most advanced cancer research and treatment centers in the US and very well known around the world. And we really focus on how to accelerate research, how to bring the best efficacies to the point of care, and really how to get closer to our patients and providers as they travel through this journey, sometimes very challenging for them. So really excited for today.
Great. Katie?
Hi, y'all. I'm very honored to be here among these folks. My name is Katie Drasser. I'm the CEO of Rock Health. We exist to make healthcare massively better. A little South by lore, we were launched here, maybe not on this exact stage, but in 2011 as the first venture capital fund in digital health in the US. And since that time, we've been centering equity and innovation in digital health so that it actually works for patients. We now have a flywheel and have grown over the years. We still have a venture capital fund. We have an advisory business, and we are all owned by a nonprofit accountable to that very mission. My background is in public health leadership. I was at the Aspen Institute for 10 years, working with leaders around the world on how to make health massively better. But I also care a lot about innovative finance, new forms of capital, and have done a lot of movement building in my time. And that's what I'm doing here at Rock Health, is supporting leaders like you all and these folks, and how can we be a force for good for the ecosystem. So happy to be in this conversation.
So as you can see, 3 leaders, innovators that are dedicated to making sure that health technology advances in service of patients. And for the 3 of you, I have first a question generally. So innovation is a very technological term, but trust is usually not considered that. It's a human term. So I'm going to ask each of you, what the role of trust is in healthcare innovation. And I'll start with Josette. From a patient innovation perspective, where do you most often see trust erode? And how does that influence how you design digital solutions?
Yeah, no, happy to start and kick us off. So, trust is a relatively ambiguous term, right? It requires you to assert certain subjective value statements associated with it. In many respects, trust is something that is very individualized. So I'm going to maybe start off by just posing a question. I would love to just see hands, some level of participation. So think about yourself, right, in terms of your experience with the healthcare system. Many of us are patients. I always laugh when we talk about patients as this third party, this other, but the reality is we're all consumers and interactors of the healthcare system, or we're even caregivers too as well. So when you think about the experience that you've had and the level of trust you have with the healthcare system, what's your level of confidence? Would you say high, medium, low? We'll start with high. What's your level of confidence? High? Okay. Medium? Wow, that's incredible. Okay, I was expecting the other. That's wonderful. And then low, I'm actually curious who feels. So, I think the medium, the low is quite representative in terms of where most people would gauge themselves as well. I think a recent Gallup poll showed or indicated that about 40% of Americans feel confident about the healthcare system. Now that's 40%, that's good, but that's not even halfway, that's not medium, right? That's 40%, so what's going on with the rest of the 60? And I think we can all probably relate to that 60%, where you are trying to navigate a system that in many respects sometimes feels out of reach. You are experiencing symptoms, you may want to get on that appointment book, you call the doctor, when can I get an appointment? And this just happened to me recently, where they're like 4 months from now. I'm like, well, how does that work? Because I'm experiencing the symptoms now. 4 months, like where will I be? What will be going on? When that 4 months rolls around, you go in, you get your 20-minute visit, and in that 20-minute visit, we need to run more diagnostic tests. You need to now create another appointment. That other appointment takes you another 2 months. And you see how the trust starts to break down very easily. Because once again, with that level of complexity, despite having ownership, despite having agency, it feels overwhelming. So I think that's why for a lot of folks, it's not that they're not excited or wanting, frankly speaking, to be able to get the answers that they want. It's just hard, frankly speaking, to be able to navigate what is an awfully complex ecosystem. So in terms of how do you build trust? Certainly from a tech standpoint, and I love, Brandon, the way you mentioned that trust is not about the technology. In many respects, I believe it's about ensuring that patients, consumers are at the table. When we're ready to disrupt and we're ready to ensure that whatever we design ultimately makes a difference for patients and consumers, that necessitates us bringing consumers and patients to the table to be co-developers, co-creators in what the new technology, what the new wave of innovation is. I'll just share, in my company, we strategically launched this whole effort called the Red Chair campaign. What that means is in every room within the organization, within the company, there's a red chair, a very bright red chair. It's a reminder that the patient's voice is needed. It's a reminder that we're all accountable to figuring out how to get those insights directly from patients and ensuring that they're there to create their own perspective around the innovations that we're bringing. So I do think in order to start generating trust, it's making sure that there's representation in the voices, making sure that the voices really truly reflect the myriad of experiences, and having them really be at the table to help design what the wave of future technological, digital innovation can look like.
Yeah, I think it's probably also worth noting your informal poll that we just did. I mean, this is a room of people at South by, right?
Yeah.
So these are people that are tend to be agents of change, very enthusiastic and optimistic. Then I do assume that if we were looking at a different population of people, I mean, I know just within my immediate circle of personal friends, like generally feelings are pretty low about their confidence in healthcare innovation. Question about the red chair real quick. Does the red chair, so does that mean like in a room of chairs, one of them is red, that means somebody is going through something? Or what is the analogy there?
So I think, it's very easy, especially in sort of a corporate environment, to get so fixated on some of the things that from a corporate lens will mean a difference for us in terms of innovation, will mean a difference in terms of what we do as a company. But at the end of the day, why are we innovating? For what end, for what reason? The red chair is meant to remind people to get back to the fundamentals of making sure the patient is at the center. So as opposed to what's good for the company, what's good for the patient, getting back to the problem statement at hand. And so that red chair is meant to be that visible reminder, but that visible reminder shouldn't just be visible, it should also trigger, well, do we have the patient voice? If we don't, let's find out how we can appropriately and compliantly get that patient voice so that it is represented.
Gotcha. Simon, at your organization, you see a lot of patients, you help a lot of patients see them through their entire journey, particularly in oncology, you mentioned. From a health systems side, what are some of the moments that you see patients being the least confident in how technology is being used?
When you see, most advanced technologies are not being adopted or we're not able to scale it, it kind of, speaks directly to the trust factor because trust is what turns innovation into something that actually improves care. You see the efficacy change over a period of time. And for us, it's the patient and the care team, right? The interaction between the two also really, really is important for us to get right as we introduce technology into the ether for us, right? And as we continue building it, we've learned that innovation should be invisible, meaning that we roll it out and we see all of a sudden how the physicians are adopting it, how patients have better access, various KPIs, Net Promoter Scores, and all the various things that you all are familiar with, right? But a number of things that we keep in mind that I wanted to share with you all is that, first and foremost is, the transparency. Patients and providers want to understand the how, right? How is this supporting us and where is it taking us, right? They want to make sure that human-led, right? We use all of these advanced technologies to bring the right information at the right place at the right time, but we want to make sure that it's not replacing human wisdom, and they see that because now they're getting better interaction with their physicians, more time with their physicians, etc. It's they understand the accountability. Who is making the decisions? Where is that accountability lie? And as we go forward, and when you see it proven in real workflows, right, whereas the physicians have less clicks to make, again, it's invisible. All of a sudden, and we'll talk about some of the technologies that we have deployed later on, but they actually are more and more inclined to ask the patients to use the systems that we put out there. And of course, it has to be clinician and patient informed as we, when you talk about the red chair, to me, it signifies the voice of the patient and the voice of the care team. And the care team is more than just the physicians, right? It's also all the caregivers that surround the given patient at home, right? Maybe a cousin, maybe a parent, maybe a child, right? That, we try to really bring that ecosystem together in a way that trust moves them forward together through our digital solutions.
That's great. I'm curious, Katie, from your perspective and from Rock Health's perspective, are there categories of technology that you see earning trust versus some that are maybe losing trust?
Yeah. It's so funny talking about trust, and I like that you said earning trust, because if you're a startup or any company and you're peddling trust, like, I'm not buying it. If you're selling trust, I don't trust you. And we see that in our data. We do a consumer adoption report every year. It's coming out next week of like what folks trust and what they don't. More than half of folks in the US look online for information, and they only 7% trust it. Sorry, 7% women trust it, 12% of men trust it. Women are a little more skeptical. But so they want to find it online, they want to use technology, but they don't trust it. So how do you earn trust? If you're selling me that we're going to be on this journey together, that I'm going to care for you, that here's some transparent data, that like you're going to show up, maybe not make me wait 4 months, I might trust you. The other place we see of the people who do trust information online and where people are going, we heard from Reddit yesterday. Our team was actually sort of surprised by this, if I'm being honest. But then to understand why, people trust their peers. They trust someone going through the same thing. If you look at a arguably non-tech model like AA, you know it has no business model, there's no revenue, no transactions. It succeeds because people are supported by peers who have been through it. They trust that opinion, and recovery rates are higher because of it. So there's a company called Marigold Health, a startup company, and they have AI supporting peers, supporting folks going through recovery. In their first 2,000 patients or folks using their platform, peer-to-peer, supported by technology, 98% recovery. And they're just getting started, right? Like 2,000 people, I know it's like a small sample size, but that's pretty impressive. And it's because folks trust peers, but where the tech comes in is the tech is in service of that. It's in service of that, those outcomes and that trust, rather than the other way around. And you can find more of these examples. We also see the startups that are working that are built by people who are the peers. So if you have lived through something and now you're building a company against an innovation you're excited about or a pain you are solving for yourself or your family, I'm gonna trust that like your stick-to-itiveness with that company, that you're gonna build that right because you're building it out of your own lived experience. And so that peer piece, just rounding out some of what you all have talked about, we see that as a category, and then you can play that out, whether it's on Reddit, open evidence, you know, peer-reviewed journals, peers building innovations, and then also folks like Simon and Josette who are within these companies, they are our peers, and I trust them to do the right thing within those companies. So I think the peer-to-peer lens is, I don't know if I'd call it a category, but it's a strategy grounded in trust that tech is actually massively enabling that we're really excited about.
Technologies that are facilitating peer interactions tend to be, get more. And
if I may add also,
for sure.
That's a very, very amazing point to take away, because even internally, when we want to deploy solutions, even though we make sure that the patients and physicians, et cetera, are involved from the beginning, it's the champions that really make the difference. That they actually start using it and evangelizing it within the organization. And as peers, you see that it grows like wildfire. Oh, well, these guys are using it. I'm going to start using it too. And it really, really makes a big difference when you have champions within the organization helping with the adoption of these tools, and really builds trust for them.
So I'm hearing that either the technology should be invisible, and basically you just experience results as by virtue of that technology, or it's a technology that helps peers interact with each other. Those are two maybe categories of success. You mentioned some stats a second ago. I'm curious, and I'll start with you, Katie. How exactly do you measure trust?
I mean, that's a really good question. One thing that hasn't come up yet that we think a lot about is accountability. And so if you have a product and I'm not engaging with it, I'm not trying to hold you accountable. I don't really care about you or that product. If I actually want your product or your service or your thing to succeed, I'm gonna write you, and I'm gonna call customer service and be like, I had this terrible experience. I'm gonna hold you accountable. And so I think there's a piece around accountability of and that when you look underneath that, we think of accountability as a punitive frame. And if you reframe that as no, I actually care about this. I actually care that our health is better. Then I think there's a whole set of metrics that you can measure, like usage, adoption, How much data am I willing to share with this platform? If you're not useful, if you're not transparent, if you're not delivering care or having the outcomes, like, I'm just not gonna use this technology, and then I'm not gonna hold you accountable. And so we look at a couple like accountability metrics that then play out as like common terms we all know, like usage and adoption, hence our consumer adoption report, that actually underneath that give us some signals of where trust lies and where people are trying to develop more trust through accountability and whatnot.
Gotcha.
Yeah.
Yeah. Organizationally, Simon, do you have ways of measuring trust for some of the innovations you roll out?
Well, there's formal ways and informal ways that we get feedback, and I always look at it again from patient and a care team perspective. And from a patient perspective, right? When you see increased interaction with your net promoter scores and verbatims, that means that they're engaged. They actually see that it's working. They want it to get better. And it's up to us to iteratively, continually make that platform better based on what they want to see. And and you see utilization grow. Informally, I make a point of always going our rounds at least once a month with one of our physicians. And when people are giving you positive feedback, I was able to make my appointment, it was so quick, et cetera. And I'm like, you get those feedbacks. Very heartwarming. So that's both that way. And from a care team perspective, durable trust really comes about when, you're saving time for the physician, right? You're reducing, cognitive burden on them, right? And you're improving their decision readiness, right? So formally is really around the utilization of the system that you can capture, but informally is when we rolled out our Hope LLM solution that you guys will hear about later, and you get a hug in the hallway. It's like, man, this was really has saved me time. And the patient feels it too, because now they get more time with the physician with these kind of technologies. So you just kind of have to put formal and informal together and continually make it better in order to build that trust. If you let that erode, or you just drop the ball on continuous improvement, then you have another battle to fight.
Yeah, that makes sense that you would have both aspects. You would have something formal to try and measure and use analytics to make sure, but also just the feeling that you get when you see somebody who's benefited from a technology you've introduced. And I imagine, Josette, that's similar for your organization, where I know that analytics and measurements. Well, let me not assume for you.
No.
How do you measure trust?
Yeah, no, I do think it's multifaceted and it's multi-layered. I almost view it as like the stories, right? In terms of the when I say stories, like levels within a building. I think baseline, and you've obviously recognized it from Katie as well as Simon's response, reach, frequency of the reach, engagement. Are you actually getting to the patient segments and the populations where this specific innovation or new unique digital channel was created and designed for? So to me, that's all just the starting point. What actually is the hardest, as in our case, where we are designing things to address care gaps. The question then becomes, when you've actually put this in market, you are seeing the engagement, you are seeing activation. Have you closed the gap? That seems very simple from a question standpoint, but what we've obviously come to realize and appreciate is the complexity of ascertaining that and answering that. Did we close a care gap? Did we make your experience less painful? Mm-hmm. Did we enable you to get that screening? Did we reduce the time from screening to diagnostics? Did we support treatment initiation? Like, when you start to go through all of those levels, what it requires on the back end from a data triangulation standpoint isn't easy, right? So I think we're learning and growing and maturing in our sophistication from an analytics standpoint, because at the end of the day, trust, going back to yes, they're engaging with the technology, yes, they're engaging with whatever innovation, but it's what means to what end? The end being, this has actually helped me. The end being, this has helped me navigate, and now I'm able to get X, Y, and Z, whatever is important for that consumer. So we're learning a lot. We've had to really invest a lot, both in the data and how you bring different pieces and sources of data to get a much more complete picture. How do you put the right level of rigor from an analytic, algorithmic standpoint, so it gives you a sense of, yes, this actually made a material difference. So lots of good learnings on the good side, on the bad side too as well, because that to me is fundamentally what is the most important part of measuring trust, is the degree to which it made a difference in the experience. And then ultimately where I'd love to go to from a North Star standpoint is not just in the experience, but in the outcome, because that's what we're all striving for.
Can I build off something, Josette? I think what you're saying is really, really important. We often say, if innovation is not equitable, it's actually not that innovative. It's kind of lazy. Those questions you're asking as it relates to care gaps are some of the most important. And we see it reflected in our data. In recent years, the highest and fastest adopters of digital health tech, whatever you want to call it, are Black folks in the US compared to their peers. They are also the least satisfied. So there's an opportunity there, how can we do better? What might that look like? And those questions help get there. Satisfaction kind of gets thrown around as does this matter? People want health outcomes. Well, if I'm not satisfied, I'm not going to use the product. I'm not going to take the pill. I'm not going to do the thing. If I'm not, it's a step along the journey, because outcomes take a long time to get to, and closing those gaps. But those are some of the things we measure and pay attention to. And then look at, folks are raising their hand asking for this. The demand is there. And who's at the table asking these questions? Who's pushing to fill those gaps is one of the most critical questions.
So just to riffing, sorry, Katie, but the point around even then drilling it down, right? Because we unintentionally, I think about consumers, patients in a very monolithic, right, standpoint and lens. Mm-hmm. And so to your point around even then really disaggregating that data, because you could see engagement, you could see satisfaction within one cohort or group and not, right? And to your point around, if you're really designing with the intent of reaching and engaging as many, then there's another layer of complexity to how you disaggregate the data. I think people often just assume a lot of big corporations have the ability to do that. Mm-hmm. It's not necessarily. We are going through the growing pains of, number one, making sure that as the data is coming in, we are immediately asking those critical questions, because it helps you decipher what data is needed and how you further filter that data to get to some of those fundamental, right? So you can see some of those fundamental observations, which helps from an iterative standpoint in terms of, well, this is working for this group, but it is not working for this other group. Mm-hmm. So what's the material difference that we need to be cognizant of to make sure we're actually innovating for all?
Yeah. And not to get too geeky on you guys, that's what makes it really, really important to have a longitudinal view of your patients within the organization, right? That includes, genomics, social determinants of health, clinical information, all of these things. They really come together to inform decisions, especially centered around health equity as well, to make sure what you're designing is really applicable to all as much as possible.
Well, I'm pleased to announce to everybody that time is frozen and that no time has passed.
I was noticing that. It was not moving.
I have no idea.
We're never leaving.
It never left.
Roughly how much time do we have? Because I want to... Okay, great. So I definitely want to make sure that we get to talking about patient-centered innovation and designing with patients. So patient-centered is a term that's used a lot by many different organizations, became very trendy maybe 10 years ago. It means different things to different groups of people. But what does designing with patients actually require? So Josette, my question for you, with Merck's patient health innovation work, platforms like NIA and JADE, these are tools that are grounded in lived experience, right? So what does designing patients actually look like in these cases?
Yeah, So I can use Nia or Jade as an example. So I'll quickly share what was the impetus and the rationale for this specific digital platform. We had I think we were sort of taken aback from a data standpoint when we recognized and saw that for Black and African American women, their mortality rate when it came to breast cancer was 40% higher. And then when you further peel that onion back, what we also recognized was they were getting diagnosed at stage 3, stage 4, at significantly later stages, where from the standpoint of getting significantly diagnosed at later stages, that impacts, frankly, survival, right? And so we wanted to understand, well, where can we intervene? Where can we support? So a lot of work was done to better understand the drivers of why African American women, but I'll tell you guys, not to get towards the end of the post-innovation deployment, but what we quickly saw was a lot of the health systems that now are deploying our digital platform, the ask has been, can you make this available to everyone? Because frankly, the presenting at later stages isn't just experienced by one subgroup versus another. But long story short, I think once we came to that recognition and understanding, certainly screening. We take screening for granted. We assume the minute you turn 40, everyone's getting screened. But what we're also seeing is women are getting diagnosed at younger and younger ages. Triple negative breast cancer. I just interviewed a woman, 37 years old. I'm hearing women in their 20s getting diagnosed at triple. So you're feeling that lump. I'm just, it's like, I don't even want to know what that is. I have other things to focus on. I need to do X and Y. I'll make that appointment later. So we worked really hard to build what we're calling a conversational triaging, which is to take the fear out of understanding your risk for breast cancer. Once again, we did it with African American women in mind. And so as we built this conversational triaging tool, it is truly meant to be a personalizable experience where we're understanding your family history, we're understanding when you started your first period, because all of those things matter. We've built it such that by the end of this experience, it pulls together, frankly, your answers. It encourages you to go get screened. We give you the resources where you can see which providers are around you. If social determinants of health are factors such as transportation, we link you to different resources that are community oriented to help you overcome that hurdle or overcome that hump. What we saw when we put this out there was, one, we weren't sure what the level of engagement would be. We were incredibly surprised because women were on there putting their symptoms, and now this is popping up. You're seeing this sort of virtual agent that is like, hey, do you want to learn more? I'm happy to take you through this experience. And what we observed were women really not just clicking, but actually completing this whole experience from an end-to-end standpoint. What I would say from a design, we made sure we brought this to different not just women to beta test, but different community-based organization, different voices for Black women. That's where we learn very quickly. Don't put 40% of Black women about like, whoa, that's jarring. I don't need to see that off the bat. Soften the language. When you talk about family history, don't ask it in such a very staticky way. Make it more personable. So getting that very direct feedback on the questions, the look of the avatar, how she talks, her voice, all of those things were so incredibly important and paid off, because that's why women felt like, that I see myself in this, and I'm willing to trust to go through this experience. So to your point, and maybe to the earlier point I brought, co-designing, bringing people at the very beginning stages, I think had made a very important part of how we brought this product to life, and we're learning every day. So now that we are working with health systems across the country, they're also giving us feedback from patients that are also going through the innovative tool. It's called NIA. And we're learning, we're taking it in, and we're iterating. So now we want to do this for women everywhere, we're also creating a similar conversational triaging tool for people living with HIV to help them to realize that they actually have power when they go into that doctor's office to talk about all of the available options at their disposal. So bringing patients at the very beginning has been important for us.
At the beginning, but then also in an ongoing iterative manner to make sure that you're constantly improving and taking into account new potential factors, barriers, et cetera.
Absolutely.
It's really an amazing initiative, and I think I'm really, thank you for sharing about that. Katie, you lead a team of experts in health equity, social enterprise, designed to ensure equitable innovation in digital health. What does this look like in actual practice?
It can look like a few things. One thing we haven't talked about that I may offer for this is the other place that we see a lot of trust, and this gets to how it gets designed and whatnot, it's been held pretty steady that over the years that 88% of consumers or patients trust their healthcare provider. So there is a trusted relationship there. What do you do with that? We interviewed and surveyed a few thousand family physicians, like the primary care folks, backbone of care in this country, here in the US. And a lot of them wanted to use tech. The majority of them do. The majority of them already use tech. And yet, they feel left out of all innovation cycles. And I hear in rooms, oh God, the doctors are they're never gonna adopt this. Well, have you asked them? Have you actually gotten in there with them while they're with a patient and being there? So it's not quite patient-centered, but it's where patients have trust, and how are we designing with them? What we heard over and over again from these physicians is, we would love to be involved early, and often, they don't source the tech that comes through their health system often. They're not involved in that decision. Sometimes that's true, not true, but they want to be more involved. They actually want to be using tech more than people think they are, and so to me, there's an opportunity there for patient innovation that is not just patient-centered innovation, which is not just about how might we involve doctors more, but how might we do better for patients? If that is a trusted vehicle, how do we actually support that triad of innovation? We think a lot about that. You can read the report on the American Association of Family Physicians website, but the other place we see this playing out is back to the peer-to-peer thing. Companies, so let's take startups that have startups in youth mental health. Ashley Edwards founded a company called MindRate. It's peer-to-peer, but she herself built this from her own lived experience. She has a council of youth informing the design of the product, not just at the beginning, but over and over again. And the last point I want to make about that, and it applies to the previous point, is that outcomes are better and business is better. These are actually good business, and our data has shown that when you involve youth in youth mental health startups, when you involve physicians in instances where patients are colliding or interacting, that actually outcomes are better and business is better. You actually, okay, you want to make money, great, you will make more money. You want to have outcomes, you will have better outcomes in general. Obviously, there are exceptions to that, but those are things that often get lost of okay, we'll do right. No, it's actually great for business, and it's great for people's health. And so it should be practiced over and over and over again, and not as what are we going to do with the patient?
Yeah. Absolutely. Simon, I'm eager to hear about Hope LLM. So you played a role in the development of Hope LLM, which is a generative AI platform that helps care teams and patients connect. Can you tell us a little bit about that?
Yeah, absolutely. First and foremost, I've been at City of Hope about 1.5 years now, and when I arrived, Hope LLM was something that was being developed. And I helped nurture it, move it forward, re-architect it to be scaled, et cetera. But our team was a fantastic team that we have. So I wanted to make sure to get proper credit for the work that they've done. Amazing, as a very small but mighty AI engineering and advanced analytics team. But, we talked about being patient-centric, right? And we all have felt this. Number one, we wanted to address, onboarding is overwhelming, right? When you go to a new place, right? It's always, it takes long, et cetera. Number two, repeating the story is really exhausting, right? You get one person to another, like, man, I told you this already, right? And then in our world, right, and I'm sure Merck feels, the clinical trials, access, feels opaque, right? How do I get, so we wanted to build something that could really, really help. So as an example, if you come to us, you come with years possibly of clinical notes, et cetera, as a referral or as a new cancer patient, et cetera. There's 2,000, 3,000 pages of notes. So we created a platform, Hope LLM, that is able to take all of these and summarize it for the physician, right? In a way that, where they call it pajama time, because they really go home the night before and they're studying for all the patients they're going to see the next day. We saving 2 to 3 hours per patient, per physician. I mean, we've experienced thousands of hours of savings for our physicians to be able to use this tool, for patients that are coming in. And it's made onboarding a lot easier and a lot faster for our team, for our patients, right? And then, it also is able to surface trials at the point of care. So when you come in, we can tell you how closely do you match to some of the trials that we have ongoing. And also when we want to start up a trial, we also look to see retroactively what patients do we have who are able to match that trial. Generative AI gives us the opportunity to do that work very quickly and be able to really have it available. And, when you have, the patients being able to have better conversations and you are giving physicians that kind of overwhelming time saved, that builds trust, right, in what they want to do. And it makes the whole thing feel more human because it just helps really the interaction of what folks want to do and how they want to engage with the overall system. And on the patient side, you see it, right? Doctor is spending more time with you, they're talking to you. And another part of Hope LLM, and I'll end with this, is natural language. You can talk to it, right? You're at point of care. Hey, tell me, when was the last thing that they had as a lab? What do we need to order next, right? These are the things that just makes it invisible, but it feels all of a sudden, what did I do when I didn't have it? Right.
So you bring up an interesting point when we're thinking about AI and people speaking to these large language models and data being collected and used. And this is a question for both Simon and Katie. While AI and data can promise efficiency and personalization and all of these things, save pajama time for healthcare professionals, obviously questions are raised about privacy, about bias, about ownership of that data. So how do we approach this responsibly? Maybe Katie, if you could give some thought to that.
It's such a good question. I'm not going to pretend like here's the answer, everybody, like write it down, we're good. I think even just acknowledging that we are responsible. I think there's a lot happening at like breakneck speed and people are not taking ownership and accountability. The people who are designing these tools or, entrepreneurs or enterprises or even the users of these tools. But I think just in basic terms, as you're innovating for the future, are we pointing towards more benefit societally, environmentally, et cetera, or more harm? And even if you think you're doing one, how do you ensure you're actually not doing the other? And I think the other point is we talk a lot about privacy and bias and bad data. Like that already exists. Like that's not new. We're already, as a healthcare community and innovators, this room of innovators, that's what we have to work with right now. That's not new. The tech is just accelerating it. And so how do we use the tech to actually help us do it better? Like we might actually be able to use the tech to do these things better that haven't been solved yet anyway, before the tech. And that's where I get a little optimistic is the innovators and the folks who are actually figuring out how responsibly using the tech to get at these very issues, like at their root, to then go build all the other things.
Yeah, I mean, so being responsible for privacy, bias, those sorts of things, and knowing that you have that responsibility to try and make the technology better for patients, obviously I think everybody would agree that that is the goal. But we do know that there have been cases where technology maybe has made the experience worser, right? Has widened gaps. So Josette, how do you avoid that? How do you avoid actually inadvertently widening gaps for underrepresented patients through data bias and things like that?
It's such a good, I was just even thinking, Katie, as you're just from a responsibility standpoint, I have another Merck colleague here. We literally go through trainings all the time now. We are required to sit through like 30 minutes of training on just how we use AI responsibly and what the expectations are of each of us in terms of how we leverage it, when we leverage it. So I think organizations also have a responsibility around how you put some of those safeguards and guardrails. But in terms of how this can exacerbate inequities, I think it absolutely can. Once again, it goes back to how are you ensuring that as you are going through the product innovation life cycle and pathway, you are thinking about all, and by all meaning the lived experiences of individuals, of consumers, of patients, and how are you taking all of that into account as you're designing. One of the things that we did, because we recognized in order to ensure that we're not also becoming another piece of this bigger problem, is we actually did a lot of work internally from a data standpoint. We built up something called the Health Equity Analytic tool and dashboard, where we now use it as a way to help us understand who, from a disparity standpoint, has more disparities, be it from an incidence, prevalence, outcomes. How do you wrap around an understanding of the social determinants of health, factors and variables that could be contributing to those disparities? Based on that information, when we are thinking about the care gaps that we want to solve for and design around, how do we then ensure that maybe perhaps we deploy in this geography, but we don't deploy in that geography? And we're deploying in this geography because guess what? The need, the unmet need, is incredibly higher than, say, there. So using that as a basis to also get more precision and focus around where we feel, from an innovation standpoint, what we're bringing to the market, first of all, addresses the needs, but then also, once again, we know that, because we can quantify it, that there's a need there in order to ensure that we're not exacerbating some of those inequities. So I do think certainly using a data-driven approach and lens is important, but also it kind of goes back to making sure that you're having conversations. You are literally having conversations with community members, community organizations. And I would say for an organization like ours, Merck, that's not something we were historically very good at. It's like, well, how do you have conversations with the community? What is that? I remember looking at them, what does that mean practically? Are we going to be going everywhere? It's like, no. But we do make a very valid sort of intentional approach to ensuring that, once again, in those communities and areas and regions where we feel as if, like for NIA, we started out with 10 states. We didn't start with all states. We started out with 10 states. Why those 10 states? That's where we saw for Black women, they were getting diagnosed at even a significantly later stage in the process. So guess what? Let's go there first, right? So I think that kind of gets back to just making sure that you are taking data that's informing a lot of your decisions, and you're making sure you're having those robust conversations to know that this will fit in with the lived experience of the audience and communities you're trying to support.
Yeah, makes sense. I have just one last question for each of you, and that is looking into the future of technology in healthcare. Next 5 to 10 years, what's one thing that you're really optimistic about that you think might actually make a change? And I'll start with Simon.
Tools that reduce fragmentation for physicians, I think, is where I would go, because, we're in the age of agentic AI, right? And now making sure that you have the right tools to be able to orchestrate these agencies, and bring the information and really not address the fragmentation, right? I have a little information here, a little peer-to-peer there, a little this, right? That's where it's going to go, is that being able to create pathways responsibly for the physicians and inform the patients as well and move them to work together at the same time. I think that's going to really, really be the direction that we want to go, but I emphasize responsibly, right? Because in healthcare, it's important to understand that innovation can't outrun trust. So you've got to work together in order to move it forward. And the technologies that are coming our way now gives us the opportunity to do that if used properly.
Cool. Katie, what's going to be cool in 5 to 10 years?
I think any place where there's an outsized demand and tech has an unmet demand and tech has an outsized role to play in meeting that demand, whether it's the menopause space, more broadly women's health, the youth mental health space, the primary care space. There is so much demand. People are so unsatisfied. And I do think tech can really help close those gaps and play a role in matching a provider that looks like you, a solution that you don't have in your community but you can get access to, something that is designed by people that are more, share some of your experience. I see it a lot with startups. For the bigger enterprises in the room, look at who those founders are. Like, you could try to build it in-house. They might have that trust. They might have built this very thing. Like, consider supporting them, bring them in-house, giving them a contract. Like, they built that trust organically in a way like you won't be able to build that fast. And see them as your partners, not your competitors, is what I would say.
Great. Josette?
Oh gosh, I would say maybe 2 quick answers. One is, let's not underestimate the power of using technology to support patient navigation. With my earlier first response about where do you see people, frankly, just falling through the cracks? Where do you see the greatest mistrust and friction? It's at that early stage in the journey. So I think there's a whole lot more we can do to create much more of an integrated, seamless experience for individuals like even myself, and the power of navigation and what that looks like. I think there is so much disruption and excitement that I think a lot of companies are realizing we need to focus and hone in that area. The one thing I'll just also say is, I also appreciate the fact that we're not getting fixated on the technology. I think you're seeing a whole lot more robust conversations happening around bias, happening around ethics, happening around satisfaction. And so to me, in the next 5 to 10 years, it's going to be those conversations, and it's going to be how people take the insight of those conversations to help inform the design of whatever it may be that excites me. Because if you let the innovation and the technology outpace the humanistic lens and elements, we're not going to solve for any of the things we've just talked about.
Yeah, so I think we are at time. First of all, through this conversation, I know we've heard, and I think it's a recurring theme, that technology itself should be informed by the challenges that are born from conversations with patients that we're trying to serve. I want to thank the insights from our panelists here, and of course, those of you in the audience that contributed to the conversation, thank you as well, and we'll see you soon.